the examination or during exams. So I just want to clarify that if you have an understanding of these miasms, it often helps us to select a better remedy other than just seeing the symptoms of the disease. We get better opportunity to understand the depth of that medicine, whether this particular remedy will cover that particular pathology in the similar depth as what is required in order to cure. So here I present a case of a 52-year-old female. So I always believe, just theoretical preaching would not help anyone. So better is we need to, correlate with the live case examples and understand the concept through the cases. So it's a case of a 52-year-old female. So basically, she presented with a history of epigastric pain since 24 hours, and the pain was within the abdomen, especially in the epigastric region, and the sensation was sore as if she's been hit. There was a lot of heaviness and tightness around that abdomen, and on examination and while palpation, we felt that there is some amount of distension of abdomen. All these things started after she had fasting. She had kept a fast, and thereafter all these complaints started. And the symptoms were better when she would bend double or she would draw the knees towards her abdomen. She would feel better, and she would be aggravated lying on the right side, and all the symptoms are worse at the night. So here we have 52 years female who's coming to your OPD with the complaints of abdominal pain. She was in distress. The duration of illness is 24 hours. Pain as if something has been hit inside the abdomen. She had a history of fasting, and she is worse by lying on the right side. She is relieved by bending double. She is worse at night. She was tossing at night. All throughout the night, she was restless. So, how do we receive this patient? Patient is in pain, distress. Now, here, the first question is whether we receive the patient or we hand over the patient to a modern medicine counterpart where they can just give some form of painkillers and relieve the patient. So that was a question in my mind, and I think all the members would also have the same similar question: okay, whether we should put our head into such a type of case where the person is in distress and in acute emergency. The pain was radiating to the left and right, both the hypochondrium. So here, epigastric pain radiating both the side, both the hypochondrium, and patient is in distress. So what do we do? Similarly, along with the abdominal pain, patient also had vomiting. Vomiting was greenish, watery. So, so there is another symptom. First symptom is pain, distress, and the second one is the vomiting. Another symptom like the taste in mouth. She is already a known case of hypothyroidism. So here we have 52 years old female with abdominal pain, vomiting, bitter taste in mouth. She's restless. She's been tossing all throughout the night, and she has come to you in the OPD. While examination, you find there is a tenderness. It's a significant tenderness in epigastric region, umbilical region, and right and left, both the lumbar areas. As in when you auscultate, you find the bowel sounds are absent or poor. So here I would like to say, if the patient is complaining of distension of abdomen, first thing is palpate and auscultate. So if you auscultate, if and you find there is a bowel sound which is sluggish, poor, and it is almost nearly absent, that means there is some form of problem with the intestinal peristalsis. Okay, so there is sluggishness of the peristalsis, and that's why there is no peristaltic sounds. And as I had already mentioned, patient had distension of abdomen. When we measured her abdominal girth, 113 centimeters. So again, here it is very important to maintain the abdominal girth and measure it regularly, because this will be one of the indicator to understand whether we are actually treating the patient or patient is getting worse. As I've already mentioned about the bowel sounds, that is another indicator while we are treating any abdominal pathology. If the bowel sounds are not reappearing or it is not been heard, that means we are not on the right track. So these are certain indicators or clinical sign which we should be alert. Another important thing on general examination which we found was she was significantly having pallor. It was a significant pallor. All other vitals were good. So here again, abdominal pain, vomiting with tenderness in epigastrium, with poor bowel sounds, and abdominal girth of 113 centimeter. So now I think now it is important to understand that what is the diagnosis? What are we handling? Because diagnosis is the foremost thing which we need to be clear about before we proceed. Other general symptom which was there in the case was thirst increased and profuse perspiration. So here abdominal pain, vomiting, poor bowel sounds, tenderness in the abdomen, and pallor. So these are the things which are there in your case, and we need to reach the diagnosis. And in order to reach the diagnosis, we need certain sets of investigations. Okay, I think everybody is with me. Abdominal pain, vomiting, poor bowel sounds, severe tenderness, pallor, and now we need to investigate the patient. So what are the investigations we would be looking? First and foremost thing is, basic thing is CBC. So when I sent the CBC, it was 8.6, hemoglobin was 8.6, WBC count were around 8,800. So WBC count was 8,800. I think it is not seen here. Another important thing is epigastric pain. So another thing is we should do a liver function test. And when we did a SGOT, SGPT, so it was marginally raised. It was marginally raised, still in double figure, but raised. Alk phos, alk phos was 126. So here I would like to explain that SGPT is a specific indicator of hepatocellular inflammation or hepatocellular pathology or any hepatocellular degeneration. So SGPT is quite specific for a liver cell. SGOT has multiple sources for it to be secreted. One is liver, another is heart, and there are few other sites like intestines. So SGOT is not the specific indicator, but SGPT is more specific for the liver. So here in SGOT, SGPT both are raised almost of the similar thing, similar range. Alk phos is one of the enzyme which is specifically to do with cholestasis, where there is biliary stasis in the liver and biliary system. That that time you will find alk phos, alkaline phosphatase, which will be raised. So here it is 126, which gives an indicator which is marginally raised. So there is some form of biliary stasis which is happening. SGOT, SGPT is marginally raised. So here is our main culprit. So when I did amylase and lipase, it was very high. So amylase was 100 and 1140 and lipase was 4000. It was very high. So what does it indicate? Amylase,
Pancreatitis.
very good, very good. So it indicates, so first amylase is high, and only based on amylase we cannot label that this is a pancreatitis. It has to be supported by lipase. So the lipase was very high. So this is a gold standard investigation which will give us a conclusion that this is a case of pancreatitis. So now 52 years, female who's come with severe abdominal pain, tossing about entire night, and she has severe tenderness in the epigastrium. She has come to you with high amylase lipase. Okay, so and she is now suffering from pathology of pancreas. So now one thing which I would like to tell the group is pancreatitis is one of the most dreaded abdominal pathology which can land up with complications and it can lead to high mortality. So we have to be very careful when we are handling a case. Now, specifically when this lady has got increased abdominal girth, that means there is inflammation in the pancreas, which has also spread to peritoneal layers, and it has lead to some form of fluid extravasation. That means there is post pancreatitis ascites. Pancreatic ascites has formed. So imagine now you are handling a patient which has got inflammation of pancreas, which is reflected to the amylase and lipase, and along with that, she has got pancreatitis or pancreatitis induced ascites because the abdominal girth is 113. Now, what is the next investigation which you would like to do? Anybody from the group? You have diagnosed the pancreatitis based on the biochemical examination. It's a biochemistry. Now, what is the next stage?
USG
USG
abdomen.
abdomen.
USG abdomen pelvis.
Very good. USG abdomen pelvis. Why you want to do USG abdomen pelvis?
To check out any gallstones that can be obstructing, because that is one of the common causes of pancreatitis acute.
Very good. So you want to, your purpose of doing USG is to find the etiology. Okay, you are Dr. Sadiai, right?
For Dr. Forum.
Dr. Forum. Oh, sorry, Dr. Forum. I could not see the side video screen. So yeah. So you want to find out the etiology. Any other reason for doing a USG or imaging? So now we are talking
to
about
to
imaging.
see the status of ascites.
Very good. To see the status of the ascites. And what else? What is the other indication for doing a imaging test? We are dealing with which organ?
Other organs are affected or not, like kidney,
Pancreas
Pancreas.
kidney,
pancreas
fish.
only.
Yeah. So we are dealing with inflammation of pancreas. So whether we should look at pancreas or no, we should look at pancreas. What is the status of pancreas? So there is a indirect indication that there is a pancreatitis, but we have to go down and see how is the pancreas, what is the status of the pancreas. You understood? So this is what we learn in pathology. When we see pathology, we are just seeing the pathology which is reflected into in the bloods through serum amylase and serum lipase. But what is the actual status of pancreas needs to be evaluated, because the mortality and morbidity of the patient or the prognosis of the patient, specifically the prognosis of the patient, is based on the status of the pancreas, which can be evaluated through imaging. So imaging is a basic imaging and a specialized imaging. As Dr. Forum has already mentioned, there has to be a etiological understanding why this lady has developed the pancreatitis, and that would be clear from doing a basic imaging like sonography. But if you want to go further and do a better investigation, so there is a CT, and the best one is to do a magnetic resonance cholangiopancreatography, MRCP. So as a homeopathic physician, we should not be scared of advising investigations, because there are investigation, these investigations will only help us to diagnose a case. But before we advise any investigation, we should be clear with what is the understanding and what is the pathology we are dealing with. So other important parameter which we did was electrolytes. So here if you can see poor bowel sounds and potassium. So what is the correlation between poor bowel sounds and potassium. Anybody? So if there is a hypokalemia, if there is a hypokalemia, then the bowel sounds may reduce because it is due to paralytic ileus. You must have studied in surgery. If not, then you'll study it in surgery, right? So there is something called as paralytic ileus which develops because of low potassium, hypokalemia, and here patient had vomiting. So when there is vomiting, we lose potassium from the body, and that is the reason why she was having hypokalemia, and this hypokalemia had resulted into poor bowel sounds. So I am trying to correlate symptoms with pathophysiology and how do we see and look into the investigations. So all these things are very important. Another important prognostic indicator in a case of pancreatitis is serum calcium levels. Serum calcium levels are very important because the vascular calcium or the blood calcium is being used up during pancreatitis, and it may lead to saponification of the pancreatic gland, and that is the reason why the serum calcium may drop. So serum calcium, if it is less than say 8, is a severe severity index indicator according to Ranson's criteria. So there is something called as Ranson's criteria in a case of pancreatitis. If serum calcium is less than 8, so you have to keep a close watch on that patient, or else the patient will get complicated. Patient will develop various complications because of pancreatitis, will become hemodynamically unstable. Another important thing is to know the quantity of, or the quantum of inflammation, that is 207 CRP. C reactive protein was 207. So again, it means there is a massive inflammation which is going on in the 8.6, 8.9, calcium is 7.4, SGOT SGPT is raised, and amylase is 1140, and lipase is more than 4000. So this is what we are handling. Then the visualization of the pancreas are better on the compared to the pancreas, because pancreas is often being hidden because of the bowel gas or the gases which are there in the intestine. So sonographic visualization is little difficult. So it significant peripancreatic fat stranding and interfacial fluid. Multiple non-enhancing focal areas was seen within the neck and the body of the pancreas, which is because of the necrosis. So what is more important is this. According to the CT scan, around up to 30% of the pancreas were necrosed. So imagine, out of the entire pancreatic length, 30% of the pancreas have been necrosed. That speaks volume about the intensity of disease, and how important it is for all of us to be alert when we are handling such a case with homeopathy, because anytime patient may get into complication or patient may become hemodynamically unstable. So here the take home message is, when you're treating a patient with homeopathy, especially if it's an acute emergency, so and it is in a critical stage based on the investigation, then we have to keep a close watch by doing a regular monitoring. So here the role of hospital in homeopathy is very important. So if such a case you give homeopathic medicine and you send it home, you will not be able to manage. Here the indication of admission is the severity of disease, plus she has significant anemia. Third, her calcium level is very significantly low. Fourth, patient is having hypokalemia. So patient needs to uh, be managed in the hospital, and it requires a proper support in terms of medicine and also the potassium correction. regular monitoring of the patient, keep a close watch on the abdominal girth, and a close watch on her blood pressure. So, are you all understanding what I'm trying to tell? Am I audible?
Yes, sir.
Yes.
Yes,
Yeah,
sir.
yeah. Okay. So I'm just seeing the PowerPoint because I'm not able to see uh, the audience. So here, as I had already mentioned, the better imaging techniques are very important. Now, as Dr. Forum said that we have to rule out gallstones. She was absolutely correct. As you see in the previous scan, there was no mention of about the gallbladder stones. Here, the gallbladder was reported as normal. So it is said the rate of picking up gallstone is higher on sonography compared to a scan, and it is equally high in MRCP. So here we wanted to know not only what is the etiology of this pancreatitis, that is, we have to rule out the gallstones. What is more important is we wanted to see the entire biliary system and also the pancreatic duct. So that was the reason why we did magnetic resonance cholangiopancreatography. Cholangiopancreatography means you are going to visualize everything related to the entire biliary system and the pancreas and pancreatic duct. So here you're going to see liver, hepatic duct. You're going to see the cystic duct. You're going to see the common bile duct. You're going to see the pancreatic duct and the entire length of pancreas. Because if we diagnose gallstone, the gallstone in the gallbladder is not going to produce pancreatitis. It is these stones which travel outside the gallbladder. It goes and obstruct the common bile duct or the pancreatic duct, then only the pancreatitis will be precipitated. So here, that's why we did MRCP. So if you see MRCP, it is showing acute edematous pancreatitis. The pancreas are swollen, inflammatory exudation is there. There is a as there was a distension of the abdomen. So here it is reported there is a free fluid, which is because of the pancreatic inflammation, which is seen in the peritoneal cavity. Okay, so and it also shows there are multiple stones in the gallbladder. Can you see this on the MRCP about the gallbladder? The last line, gallbladder exhibits multiple calculi, and as the measured, the highest size is 9.2, I think, without the gallbladder wall thickening or inflammation. You're understanding? We received the patient, we took the history, we examined the patient, we were suspicious about certain thing, we sent the blood test, we confirmed the diagnosis, we over confirmed the diagnosis by doing an imaging technique, and now we also found out the etiology of the pancreatitis. You understood? So there will be a presentation of a disease. We have to track down what is the etiology of that particular disease. So now this is a definition of Atlanta definition. It's a revised Atlanta definition of morphological features of acute pancreatitis. So there would be a collection variable amount of both fluid and necrosis associated with necrotizing pancreatitis. The necrosis can involve pancreatic parenchyma and the peripancreatic tissues. So as we were talking about what are the etiology, in our case it's gallstones, but there are other multiple etiologies like alcohol, which is very common. Other important etiologies are hypertriglyceridemias. So patients who have got uncontrolled triglycerides and cholesterol, and specifically it is around reaching a level of thousands, they can land up with acute pancreatitis. Traumatic pancreatitis is common, and drug induced pancreatitis is common. Another important cause is post-infective pancreatitis, especially the mumps pancreatitis, are common, especially in kids who develop these childhood infective illnesses. So here, acute necrotizing pancreatitis with acute necrotic collection, and it is due to gallstones. So this is a diagram which will clear our doubt why and how these gallstones produce pancreatitis. If you can see very clearly, so these are the gallstones. They are silently sitting in the gallbladder, and these gallstones, because of the gallbladder contraction, especially after the food, after there is a heavy intake of meal, these gallstones, they travel through the cystic duct and they come into a common bile duct, and there it goes and settles and get impacted at ampulla of veta, and this will block the flow of pancreatic juices into the intestine, into the duodenum. And these blocked enzymes are autolytic enzymes. It produces auto digestion of the pancreatic tissue and the parenchyma, which precipitates the pancreatitis. Are you all understanding? I hope you understood.
Yes, sir. Yes, sir.
Yes.
So you understand that lady, 52 years, female, she had a episode of fasting, and that fasting, and thereafter she landed up with abdominal pain, with a distended abdomen. She was anemic with amylase of 1140, lipase of 4000. Then we saw that there is a pancreatitis. Then we tracked down this gallstone, and now we know how these gallstones have obstructed the pancreas and pancreatic duct, and it is not allowing the pancreatic juices to come into the small intestine. Instead, it is leading to auto digestion or self destruction. This is known as self destruction because these juices are not finding the vent to get into the small intestine. This is a better two dimensional this is how. So if these gallstones, now gallstones have already started with one form of complication, which is pancreatitis. So we are handling a complicated gallbladder. Complicated gallbladder means in these gallstones, which was sitting silently in the gallbladder, has now started creating mischief. And the first mischief which they have done is they have obstructed this pancreatic duct and led to self destruction of the pancreas. Another mischief which they can play is they can obstruct the common bile duct, and that will lead to what the entire bile will get accumulated into the biliary system, and it will spill over into the circulation and lead to obstructive jaundice. Another mischief which they can play is this gallbladder, which is in adjacent to the pancreas. It can evacuate the stone directly into the intestine by forming a cholecystoenteric fistula. So what will happen? These gallstone will go and directly empty itself into the small intestine, and once it is entered the small intestine, it can go and obstruct ileocecal junction. So then the patient will land up with mechanical obstruction or intestinal obstruction. You understood? Ileocecal junction is a very narrow section of the intestine. So once the stones are passing through the intestine and it enters that area, there are higher chances that it may obstruct. Another complication which it can produce is pus formation. There can be a suppurative cholecystitis, and it may also lead to carcinoma. You're understanding? So these are various complications the gallbladder stone can produce. So when a patient comes to you, they are coming with a gallstone. You should be aware that these are the complications which can be seen in the patient, and accordingly you should be prepared mentally to handle it, and you should counsel your patient accordingly. So this is a sonographic visualization of the gallstones. You can see, so these are tiny stones. So that is why the chances or the specificity and sensitivity of sonography to diagnose gallstone disease is higher, and it is cheaper in comparison to MRCP. MRCP is always done at the later stage where you want to track down the entire biliary system. This entire biliary system cannot be this particular common bile duct, cystic duct, hepatic duct, and the pancreatic duct cannot be visualized on sonography. So this is very important because we should be aware where is the stone and has got impacted or obstructed, so that we can tackle it accordingly. If you only want to study the gallbladder, then sonography is the best investigation. So this is something which you should keep, that is known as Charcot's triad. If a patient comes with fever, jaundice, and right up, only specifically right upper quadrant pain, then there it is known as Charcot's triad, which is because of the acute cholecystitis. But in our patient has come with epigastric pain, so it is more classical of pancreatitis. So trio is fever, jaundice, and right hypochondric pain. If this trio is present, then it is known as Charcot's triad. So this is another thing which you should note down and keep it in mind when you're handling a patient with acute abdomen. So complications of pancreatitis: necrosis, destruction, abscess formation. It can bleed. It can lead to bleeding. It can lead to pseudocyst formation, shock. Patient can go into shock. If there is a hemodynamic instability, patient can go into renal failure. Patient, if the pancreas are destroyed, there is no insulin, then patient can go in sudden hyperglycemia and land up with non-ketotic coma or diabetic ketoacidosis. In other words, it is known as diabetic ketoacidosis or non-ketotic acidosis. So now what we were talking about was Ranson's criteria. So Ranson's criteria is comprising of age, WBC count. Luckily, the WBC count of the patient had not increased. She was only in the inflammatory phase. She had not entered into a suppurative or so-called septic phase. So it was around 8,800. She was 52 years. So that age criteria is also not in the serious zone. But what is more important is drop in hematocrit. Clinically, how do you calculate the hematocrit? Clinically, how do we calculate the hematocrit? So the basically criteria is you multiply your hemoglobin into 3. So here the patient's hemoglobin was 8.9 into 3, so it was around 24. So 24 is not a good hematocrit. Hematocrit has to be around more than 36, more than 30. In short, it should be more than 30, and best is 36 and above. So here it was 24. So this is one thing which we should keep in mind. If it drops further, that means there are chances there is a bleed, either there is a pseudocyst formation or there is a GI bleed. That you have to keep in mind. Second, calcium was very low, 7.4. So here it is less than 8. So these are two criterias. Plus she was there was an electrolyte imbalance in terms of hypokalemia. So these three criterias should be observed carefully, because these are the three criteria which will indicate that patient is progressing towards severity. So how do we handle? Should we give homeopathic medicine or directly give antibiotics? Keep patient nil by mouth, correct the potassium, correct the calcium, and observe. Keep a check on the abdominal gut. So what what would be your approach? Whether we should go with homeopathy, because it is a very laborious process, and it is a time consuming process. So if you ask me, I always try with homeopathy. And then, so my line of management would be first nil by mouth, because patient is vomiting. So it is very important to keep the patient nil by mouth. More you are going to introduce food or liquid into the intestine, more the pancreas will work, more the enzyme will be secreted, and more will be the auto digestion. Here we don't want any disturbance into the enzyme secretion. So you have to keep nil by mouth. Patient should be given IV support. IV support is important. Even if you treat homeopathically, Unani, Ayurveda, or modern medicine, there is no replacement for IV support. If patient requires an parenteral support, we have to give parenteral support. You don't have to. You cannot refuse it, because patient will get complicated. We have to maintain the vitality of the person. The patient has to be in a good vital state in order to recover. If patient is completely exhausted, dehydrated, and a patient goes into acidosis, and then your homeopathic medicines will also not work. Then keep a input output chart, as patient, because of the shock, patient can go into renal shutdown. So we should have to. So although it is a pancreas, but all the systems of the body, all the vital systems of the bodies are interconnected. One system, if it goes into a complication, it may lead to cascade of events and lead to multi-organ failure. So we have to keep a check on input output charting also. So how do you classify whether it is acute or chronic? So this is a question which comes to our mind. So according to me, the classification is, it is a dynamic, it's an acute manifestation, okay, of the chronic miasmatic disease, because the gallstones were already existing. Gallstones cannot be produced just in one day. You understand? So this is a very important. So pancreatitis is just an acute manifestation of an underlying cholelithiasis, which was a chronic miasmatic disease, and it was already existing, which was neglected by the patient, or patient was in asymptomatic phase. So if patient is asymptomatic, it doesn't mean that patient doesn't have that gallstone. Okay, so there are something called as silent gallstone. So this is very important for all of us to understand conceptually when we want to tackle this case, because this will determine whether we should tackle the acute manifestation first or give a chronic miasmatic, whether we should give chelidonium, or whether we should give Moxol, or whether we should give sepia, or whether, so which therapeutic force we have to adopt is based on the classification of the disease. So first thing, when I get a diagnosis, I have to classify the disease. Then only I will be able to come to a conclusion that I am going to use this particular type of medicine in order to handle this particular disease. Uh, is everyone with me? Am
Yes,
I
sir.
audible?
Yes, sir. Yes, sir.
Yes.
Yes. So we have now managing a 52 years female diagnosed with pancreatitis. The cause of pancreatitis is gallstone, and classification of disease is acute manifestation in form of pancreatitis because of chronic miasmatic gallstones which are there in this person. And this person is now hemodynamically unstable. So I have admitted the patient. I have kept the patient nil by mouth. First thing I did, I took a IV assess so that I start the fluid. So I started with ringal lactate, okay, because patient was vomiting. Patient was vomiting, and I at the side by side I started a potassium drip, because 2.76 potassium. You understand? And then all these medicine, all this history was taken into consideration. First, hemodynamically stabilize the patient. If a patient is feeling giddy, patient is hypotensive, patient is in distress, immediately first comfort the patient by taking an IV assess, and lying, making the person lying down position, and don't just sit and take history. You understood? First make the person lie down, admit the patient, keep the person nil by mouth, and start the process. And it is a simultaneous phenomena. Everything should go hand in hand. So what is this miasmatic diagnosis, and why did I purposely kept the, I could have kept a slide as managing a case of acute abdomen. Why did I keep miasmatic diagnosis as the key point in this particular presentation? The reason here is I am working with all 4 years, first year, second year, third year, fourth year. So the basic query which each and every student has, okay, how do we diagnose? We know, okay, chalo, this is a diagnosis. How do we diagnose a miasm in this particular disease? And whether diagnosing a miasm is important in this particular. disease? So these are two questions which I often encounter, and many of the students, they ask these questions, and I try to answer it. But I thought it is today's day would be a best day to answer it through a case, and specifically in a case which has got an acute manifestation, or it's an acute emergency. So, uh, so now let's go with miasmatic diagnosis. So let us understand the pancreatitis and understand how the pancreatitis can be miasmatically understood. So if you have a forms of pancreatitis, first column is the forms of pancreatitis. If it's an acute pancreatitis, understand the pathology. It's inflammatory. It's probably functional. When we say functional, means it's only at the level of inflammation. And here, if we tackle the person, the inflammation can settle down. It will be a reversible. So it's a primarily a hypersensitivity or reactional manifestation here. It can fall into a miasm of Sora. So example for this is, if a person is an alcoholic, does a binge drinking, because of the alcohol induced or toxin induced, there can be a pancreatitis. Here there is no structural obstruction, or there is no calculus. And once you stop the alcohol, keep the person nil by mouth, give the appropriate homeopathic medicine, then the patient will settle down. So this such a type of pancreatitis can be classified as psoric miasm. If you get another form of pancreatitis, which is a recurrent form of pancreatitis, or it is where there is a glandular pathology which is developing, whether you see fibrosis or there is some form of pseudocyst formation. Here there is overgrowth and fibrosis which is seen. Such a disease can be belonging to a psychotic miasm. Here we can include gallstone, which is now migrated from the gallbladder. It has gone into a pancreatic duct, and because of this, there is an inflammation, glandular distortion, and pseudocyst formation. This can be classified as psychotic pancreatitis. As we go further, patient is extremely unstable. It is in a fulminant state. Patient is toxic shock. Patient is in shock. Patient is hemodynamically unstable. Patient is in renal failure. Patient is into electrolyte imbalance. And when you evaluate the pancreas, you find there is an abscess, and patient is in a state of septicemia. There is some form of hemorrhage, hemorrhagic pancreatitis. Although the etiology must have been gallstone, or it can be an alcohol, or there is some other form of causation. But here the state of pancreas is suppuration. There is septicemic state, general level shock state, and there is a bleeding which is there into the pancreas, and such a state is classified as tubercular miasm. So inflammation has now migrated into not just a accumulation, but it has gone a step ahead as suppuration and hemorrhage. So it's a tubercular miasm. As this disease progresses further, now the pancreatitis has now crossed around 10 to 15 days and now entered a zone of chronicity. And here the entire gland is destroyed and necrosed. As you have seen in our patient, we had done the quantification of the gland destruction. It was less than 30%. Here the destruction would be more than 30%, or maybe half the gland has been destroyed, and there is complete lysis of the gland. And now at this particular stage, it is not possible to generate the gland is lost forever, and the patient will develop all the complications of the loss of pancreatic tissue, like diabetes. Patient will go into diabetes, or patient will go into malabsorption syndrome, and will have to live with this particular disease forever. And such a gland is known as a syphilitic gland. Such a pancreatitis with all the complicated, which is going to remain complications, which is going to remain for a longer duration and lifelong. It's a syphilitic pancreatitis. So this is what I wanted to pass on to all my students and my colleagues. This is what we see in IPD. and it becomes very important to put the patient into these categories, because if a patient comes with psoriatic pancreatitis, I will manage with Nux vomica. Okay, if a patient comes with a psychotic, then there are remedies better than Nux vomica which can tackle. Then if it is a person is in a tubercular phase, then the remedies like Hipazolf and all the other drugs can come up. If the person is a syphilitic dimension, then the depth of the pathology will determine the selection of the appropriate homeopathic medicine, because it has to cover that particular depth. If a patient is having inflammation, then the belladonna will help. If the patient is having destruction, then Mercurius will help. Belladonna will not help. You understand? If a patient is having flatulent dyspepsia, then China will help. But if there is a destruction and with the symptoms similar to distension is there, then China will not help. So this is what we need to be very, very careful, because I have learned this after a lot of failures and after making a lot of mistakes. Since our etiology was gallstone, so we should also understand how the gallstone formation happens and how the miasm can be understood. So these understanding is based on my clinical experience. If there is any further understanding, you can always enrich your knowledge with this. You can add the your personal experience to it. So here in gallstone, majority of the time the pathology is, first is the biliary and the cholesterol imbalance which happens. So there is a biliary stagnation. Either there is a hypomotility of the gallbladder, or the enough bile is not produced to dissolve the cholesterol. So that means the solute and solvent concept has to be understood. The solvent is the bile and the solute is the cholesterol. If the cholesterol is too much in the body, there will be super saturation of the bile, which will lead to nucleation of the cholesterol into the bile, and that leads to the stone formation. You understood? This is one method of stone formation, gallstone formation. Another method of gallstone formation is pigment stones. The pigment stones means there is excess of bilirubin which is produced in the system, in the body, and this excess bilirubin is because there is a excess destruction of the RBCs. Because once the RBCs gets destroyed, it gets converted into bilirubin. So more the hemolysis, any disorder where there is hemolysis or breakdown of the RBCs or lysis of RBC out of proportion can give rise to pigment stone formation. You understood? So there the disease will originate from hematological disorder. So you have to understand two systems are connected. We are there. If there is a pigment stone, we will now not only study the gallstone but also study the hematological system, because the cause lies in hematological system and not in the gallstone. You understood? So this is what is supersaturation, and eventually there is stone formation. So now, if you understand clinically, if there is a patient coming with gallbladder dyspepsia, where the patient feels, there is a sluggish hepatobiliary functioning is there, there are disturbance. So that can be classified as psoriatic miasm. The remedies which can help is Nux, Lipo, and sulfur. If the same dysfunction gets converted into supersaturation and there is a cholesterol and bile imbalance, and there is a stone precipitation, then it is psychotic miasm. Then the remedies can chelidonium, remedies like chelidonium, natrum sulf, and thuja can help. And if once the gallbladder, there are stones in the gallbladder and there is a super added infection, the bile get infected, or there is a pyocele formation, or there is a suppuration of the gallbladder, and with some form of ulceration or perforation or bleeding, then it can be a tubercular miasm. And the remedies like Hipazolf, I'm just giving examples, there are many more remedies. Then if there is ulceration, destruction, and perforation, then the remedies like Mercurius and Hydrostis, it enters the syphilitic dimension. So this is how. And now in our particular case, if you understand here, there was a supersaturation, gallstone formation. These gallstones traveled into the common bile duct. It it obstructed the pancreatic duct and lead to necrosis of the tissue. So here the disease has begun in psychotic miasm, but it has destroyed the pancreas and it has ended in syphilitic. So the miasmatic understanding of our patient is psychosyphilitic. These are few glimpses of symposium volume, which shows how the psychotic miasm and what are the various manifestation at the level of mind, body.
Hello, sir.
Yeah.
Sir, could you please explain the previous slide again? And also the pigment stone and piles, this thing on which you decided the miasm part. Yes, yes, this one and after that also.
So I didn't decide the miasm based on the type of stone. I was trying to say this cholesterol stone is formed because of the supersaturation of the bile, because of excess of cholesterol that leads to stone formation, right? So that is according to me into a psychotic miasm because there is over stagnation and there is oversaturation. When we talk about, in our case there is no pigment stone, but there are patients who come with pigment stones. So this is specifically seen in cases which has got hemolytic anemias, especially because of say massive hemolytic RBC disorders or some form of autoimmune disorders which can lead to destruction, okay, of the RBCs, and these are then converted into bilirubin, and because of the overproduction of bilirubin, then the stone formation happens. So in such particular patients, in such patients, if they who are having pigment stones, the primary pathology is the hematological system. So that means if the RBCs are getting destroyed and there is massive hemolysis, means then such a stone will be classified as tubercular miasm because the RBCs are getting destroyed. You understood? And stone is just a end result of that destruction. Am
Yes,
I
sir.
clear?
Yes, yes, yes.
Then in my patient, there was a super saturation. Okay, it was a silent stone for all these, probably I don't know how many months or years, and patient suddenly landed with pancreas. Imaging was showing there is a destruction and necrosis. So my patient, the journey started in psychotic miasm, and now it has landed up with complication of gallstones in form of pancreatitis, necrosis, and destruction with hemodynamic instability into psychosyphilitic. So I classified into a psychosyphilitic rather than psychotubercular because tubercular patient would have been more fulminant, patient would have been more hemodynamically unstable, patient would have been more toxic, patient would have landed with probably a multi-organ failure kind of a state, and patient would have collapsed. So that kind of a thing was not seen in my patient. There were more of inflammation, accumulation, supersaturation, and destruction. So I classified it into psychosyphilitic. Am I clear?
Yes, sir. Yes, sir. And pigment stones will be syphilitic, no, predominantly because there are hemolytic anemia, so that
Yeah,
is formed.
it can be tuberculosyphilitic. Tuberculosyphilis. So there are certain hemolytic anemias which are genetic origin, like sickle cell and all. Then those such type of, or hereditary spirocytosis or something like that. Such type of disorders can be syphilitic, but it is genetic origin. Yeah.
Yes, sir. Yes. Thank you.
So,
So
so I have one doubt.
yeah. Tell me.
So when we say the patient is when we describe disease as a psychosyphilitic or SORA and then tubercular, then at that time which remedy, like antipsychotic will go first or antisyphilitic will go first? On which basis we decide that first? And second, on the stages of disease, as the disease progresses ahead, at that time the miasm can also change as the disease progresses.
Yeah. Miasm can change. Very good question. See, as the disease progresses, the miasmatic miasm will change, and so also the manifestation. So I have been dealing with more of acute, chronic, all combinations. So then what we have to do is you go with the onion peel technique. Whatever is a predominant manifestation, whatever is a predominant manifestation, you address the totality and accordingly come to a remedy. And when you come to a remedy, then obviously check the sphere of action of that remedy. whether the depth of that particular remedy is covered in this particular case, your whether your remedy is covering the depth of the pathology of your case. You understood? That is more important.
Yes, sir.
So as the disease progresses, it will obviously lead to, you know, progress of the symptom as well as the progress of miasm. Like this is a very important case, that's why I selected this case. Because what happens is abdominal pain है, bending double है, तो हम लोग कोलोसिन दे देंगे ना, easy है ना. आपको कोलोसिन देने में क्या प्रॉब्लम है, आप दे दो कोलोसिन, पेशेंट ठीक नहीं होएगा. You understood? Because the depth of the pathology is not covered by colocin. Colocin has action on the intestinal muscles, so it is more predominantly to do with intestine and muscular coats of the intestines,
Yes,
and it
sir.
is muscular. You understood? So it
Yeah.
is a remedy which is a colicky and crampy pains, and it covers the more of such type of pathologies. So here,
Okay.
another important thing which I would like to tell, you will get patients who have got a strong family history of gallstone. मेरी मम्मी को था, मेरी मम्मी की मम्मी को था, मेरे डैडी को भी था, ऐसा हिस्ट्री आता है. So there is some different concept which is known as lithymic genes. So there is a research which is going on. It has been found that patients who have got such a strong history of family, a family strong family history of gallstone, there are something called as lithic genes which are there in their body, and that is the reason why, you know, they transfer, they land up with gallstone and they transfer to the next progeny also. They send it to next generation also. So if that is a history, then it is definitely a syphilitic dimension. So such a history has to be taken into consideration. So many a time patients, they land up only with the manifestation of that particular gallstone. They come with the manifestation, or they will never come with a silent gallstone, because they themselves are not aware that they have a gallstone. Only if the symptoms are that they will land up. So here we address a chart, a photograph which talks about how the destruction in a syphilitic miasm, which is at the level of mind, okay, with the mind, morals, will, body, and at the level of emotions, at the level of intellect, how the syphilitic dimension person will react, perceive, how the body will react, and that is where the night aggravation is very common. Our patient is having pancreatitis. Pancreatitis will not have a different method of pancreas will not have a different method of functioning in the morning, or it will not have a different method of functioning at night. Why our patient was getting aggravated at night? So this is something which is individualistic to the patient, and it also has help us to individualize in terms of the miasm. You understood? So this is another thing which we have to note down. You understood? So here, how the Sora, psychosis, and syphilitic. So this is a simple harmonic motion. How the Sora is on the positive axis. It is because there is an inflammatory reactions, and how psychosis would have more of stagnation and, you know, slowness of the phenomena, and how the syphilitic can have both the dimensions. Syphilitic has syphilis can be a silent killer, which is seen through this particular aspect of the simple harmonic motion, and it can be have a acute fulminant and destructive phase also. So you get a history that, you know, the person suddenly died, you know, sudden death. Like example, in cases of pulmonary embolisms or in cases of sudden cardiac arrest. So such patients are suffering from silent syphilitic illnesses. And you find there are patients who are, you know, landed with a particular disease, and that disease, you know, landed into a super added infection, suppuration, patient ekdam bad ho gaya, then the patient was shifted into the ICU, went on the ventilator, patient started bleeding. So these are all patients who are, you know, tubercular dimension. So they are very fulminant, they are so sensitive one after another. You try to treat a first disease, some other disease will end up, some other disease will come up in the system. So they have very labile constitution and exaggerated response, exaggerated out of proportion response. So you gave a injection of tetanus and patient landed up with anaphylactic shock. You understood? There was just a trivial injury and patient landed up with continuous bleeding. Something like that. So they have out of proportion, hyper sensitive individual and over exaggerated constitution, over exaggerated disease pathology. So here the patient state of susceptibility is low, pathological expression of the disease, fasting aggravation, sudden onset, rapid progress, psychosyphilitic. So here we constructed the totality based on bogus. If you don't know, don't have any much characteristic, it is always best to make a totality based on bogus concept, because bogus is going to talk about the etiology and the pathology, which is actually present in all the cases which are in the terminal or acute states. So here the concomitant of thirst increase, fasting aggravation, abdominal pain worse lying on right side, modality is there, better bending the knees, heat aggravation, needs a fan, perspiration profuse, and night aggravation. So this was the repertorization. So here we got a remedy like bryonia, arsenic, myrrh, rustox, camovilla, china, colocin. Can we give bryonia, understanding the pathology and the depth? Can we give arsenic? Can we give myrrh? Can we give rustox? So we have to now, when the group of remedies come in front of us, we have to understand what pathology we are tackling. If you primarily see the totality, bryonia seems to be a very good indication. कि थर्स्ट भी है, फास्टिंग एग्रीवेशन भी है, प्रेशर से एम्यूलरेशन भी है, perspiration भी है. So bryonia looks to be a very, but it is an eye wash because it is not having that depth of pathology. Bryonia will not have that type. It will help in peritoneal inflammation, but here there is a pancreatic inflammation. So what we did is we cut down on certain rubrics and we took which is more specific to concomitants like thirst, physical general concomitant of perspiration, pain during, and the modalities. Okay, so the remedy which emerged strongly was Merck. Bryonia was pushed behind. So then we differentiated between arsenic, Merck Sol, Merck Core, and China. So if you see all the three remedies are, first three remedies having severe pains, cutting pains, violent pain. China has got flatulent colic, generalities, fasting aggravation is more covered by Mercsol, thirst increased. First three remedies are thirsty remedies. China is thirstless, but during diarrhea it can ask for cold water, but this will worsen the diarrheas. Basically, China is known to be a thirstless remedy. Sweating, all the four remedies have got excessive of sweating. If you understand the pathology, arsenic is known to for destruction. Mercsol is also known for destruction, and Merc core is used when there is a destruction with gangrenous changes. So if there is a vascular compromise in the tissue and there is a gangrenous and kind of a changes, then Merc core is a better indicated remedy. China, it is mainly because of the fluid loss and if the wounds are gangrenous. So depending on the pathological coverage, we thought Mercsol is a better similimum compared to other three remedies like arsenic, al, Mercor, and China. So increased thirst, pancreatitis, abdominal pain, specifically this symptom, abdominal pain, lying on right side, and bending double amelioration, fasting aggravation. We started the patient on Mercsol. We started patient Mercsol 1M, first dilution every 15 minutes. Are you are you all understanding? Am I?
Yes, sir.
So
Yes, sir.
we have evolved through a lady, 52 years, female, coming with abdominal pathology, with hypokalemia, hypocalcemia, pallor, diagnosed to be pancreatitis. Then we found out what is the cause of pancreatitis. We found gallstone. Then we understood the miasmatically, it has started with gallstone, landed with pancreatitis. Then we took the differentiation of the remedies, and now we give Mercosol 1M, and this has to be done very quickly. Yeah. All this conceptualization has to be done very quickly, because then you won't get results. Patient will become more complicated. Patient will be, will become more critical. So first dilation every 15 minutes. So acute exacerbation, acute disease, and acute manifestation needs to be tackled with full vigor and in a bulldozing technique, because it's a state of crisis. In crisis, if we are just giving one dose and sitting back, then you are pushing the patient towards ICU or towards more critical state. So you have to be very, very quick in handling it. So here it is mentioned in chronic diseases that the repetition is allowed in acute emergencies and acute crisis phase. 10 to 15 tablespoons of water, you can give it very frequently, even half hourly, or even 10 minutes, 15 minutes, whatever is suitable as per your assessment. So here we study Mercosol. Here it is clearly in bogus synoptic. He mentioned that glands as the seat of disease, sweating, any pain, any pathology in the body, Mercosol patient will sweat. There will be free secretion. There will be either salivation, or there will be sweating, and vomiting is greenish yellowish. Glandular activity is high. Patient is in a state of all forms of complication. There can be suppuration, necrosis, exhausted, ulceration. So all forms of destruction is seen in either in form of ulceration, suppuration, destruction, necrosis, gangrenous changes. Moxol covers all this. As marked clinically, the sphere of action on the disease, pancreatitis, is seen. Concomitant of bitter taste in mouth is also seen. He lies on the right side and gets the pain. So this is a qualifying modality which we have found. Although the disease diagnosis you have achieved, the remedy is covering the disease diagnosis, but it is all the more important that it should also cover the qualified symptoms of the patient. So this is a characteristic. If you classify according to Organon and philosophy, then it is classified as a characteristic physical particular aggravating modality. So it is a characteristic physical particular aggravating modality. As rightly said by Boning Hussain, the modalities are the foremost thing which are observed by the patient, and they are the strong guide to for the indication of the remedy. Destructive inflammation, Mercosol. This is a one beautiful paragraph which is given in William Borick. Every organ and tissue of the body is more and less affected by this drug, Mercosol. It transforms healthy cells into a decrepit, inflamed, and necrotic wrecks. So they understand the necrosis, that this malignant medicinal force is converted into a useful, life-saving, and life-preserving service if employed homeopathically. So in Mercosol, when I teach from forensic angle, it has got that kind of serious poisoning symptom. But if the same poison has been potentized and used homeopathically, it helps to restore the necrosis, or convert the necrotic tissue into the healthy tissues. So I have not put an hourly follow-ups, but definitely I have taken up the follow-ups on 24 to 48 hours duration. So abdominal pain was better. Patient passed stool. Bloating was still persistent, but it is was seen that abdominal girth from 113 it had come down to 108, and patient started developing the bowel sounds. So here I would like to clarify that bowel sound was restored because of two reasons. One is the Mercosol tackling the inflammation, and second, we started with the potassium drip, because both the things are important. Don't expect that you give Mercosol automatically the potassium will get corrected. Potassium has been lost from the body. It has to be given in infused into the body so that the patient's intestines starts getting into a peristaltic state. You understand? Then on day 7, abdominal pain much better, stool pass, bloating reduced completely, and it is now the AG from 113 to 102. So imagine there's almost 11 centimeter reduction in the AG. We continued Moxol 1M, first dilution every 2 hourly. Another important thing which I would like to tell all my students, when you are handling any inflammation and its complication, don't prematurely stop the remedy. If you feel अरे पेशेंट अभी ठीक होने लग गया है, अभी मैं मॉक्सॉल बंद कर दूंगा, the moment you stop the remedy, all the symptoms will come back. So it is like, when the car is broken down on the road, we have to push it till the time it reaches the garage. You cannot just push it and stop, push it and stop, it has started. You understood? So the same concept is applicable here. Don't pre. You may reduce the repetition, but don't stop the remedy. It will not complete the cure. I'm telling you, it is my experience of treating 20 years of IPD cases. So I am almost seen more than 10,000 cases. That's why I'm telling you. So now, if you observe clearly, we all not only see the patient symptomatically, we not only see the patient from the clinical examination angle, we also look closely or observe the patient closely at the investigation level. Also, if you see amylase 1140 on day 1, then on day 4 it was 115, and now at day 7 it is 19. So imagine the amylase has come down so low. But here I will like to tell you, amylase is just one aspect, because there are other glands in the body which can secrete amylase. The very important gland which can secrete amylase is salivary gland. You understood? So amylase is having two fraction. One is the salivary fraction and one is the pancreatic fraction. Okay, so more confirmatory is the lipase, which is very very gold standard investigation for pancreatitis. So when you see lipase, first it was 4000, on day 4 it is 101, and day 3 is 30. So imagine you have tackled such a uh, uh, significant type of inflammation which was there on the day 1 with 4000 lipase. In day 4 it is 101, and day 7 is it's come down to 30. Such a drastic change in the levels cannot be produced without the action of your well selected remedy. Okay, if you just expect that you keep the patient nil my mouth रखने के बाद, the lipase will not come down directly from 4000 to 101. It requires a proper therapeutic force. Now if you see the series of changes in the abdominal girth, day 1 it was 113, then it came down to 108, 106, then on day 7 it was 107, then it came down to 99. So 99, so imagine how much distension was there in the abdomen. From 99 the abdominal girth had gone to 113, so almost 14 centimeters. So that means that much amount of fluid has been absorbed by the body only after you give Mercosol. So Mercosol has helped or facilitated in the absorption or clearance of the ascitic fluid which was there in the abdominal cavity. Now another important thing is the calcium has increased from 7.4 to 7.9 and 8.1. So this is only possible after you give a right therapeutic, right indicated or well selected remedy, correct remedy. Then only this is possible. Potassium you have corrected, but calcium has to restore itself. The level has to increase on its own. I didn't specifically give a calcium drip in this case because there was no sign of tetany or anything. So I purposely was holding and trying to see how much difference my homeopathic remedy can make in the calcium levels. And if at all worst come worst scenario, I would use a calcium gluconate drip in order to restore the calcium. But luckily we didn't require it. Our homeopathic medicine helped to restore calcium from 7.4 to 8.1. Now what was more important is this particular CT scan. Now, if you see, the pancreas is now restored back. It is not edematous. Pancreas is normal in size. Mild heterogeneous density is there. Minimal pancreatic fat haziness is there, and very trace fluid noted along the tail region. So imagine there is imaging changes also seen, and this is what our homeopathic medicines can do, provided our line of thinking or the logic which we have adopted is in the correct direction. So here we have seen changes at the level of the symptomatology, changes in the clinical findings. I will say it is a positive change towards normalcy. Then changes in the blood investigations, changes in the imaging and sonography, and even the scans which we have done. So overall, the patient is much better. Patient has last week only patient had come for the follow up, and she's doing well. So so what have we learned from this case? Anybody? Yeah, Doctor Forum.
Yeah, so basically, diagnosis, which is
Yeah.
one of the most important points we cannot miss. Etiology, the investigations, because sir, I've seen in a lot of times, the investigations, like you told, MRCP should be done in case of pancreatic imaging, that should be proper. Sonography detect gallstones well. So a lot of people might do reverse due to lack of knowledge. So even that should be there. Then third is the examination that you told, that a lot of people miss on examination. Fourth is based on this, the best thing that I learned today was about miasms. That which stage the patient is. Like we can do it for each and every disease in the same way: functional, structural, reversible, irreversible, and then we can go. And the last point was the remedy. That as you told about colosins, even the first thing that comes to our mind is colosins only, because we are used to that bending double so colosins. But then we realized that what you are giving won't affect and won't sensitize the patient only, as it is not on the level that you are giving. So that's what. Thank you so much, sir. It was really nice.
So here, what is the concept of disease? What Doctor Forum said: acute necrotizing pancreatitis, hemodynamic assessment. What is more important for all of us as a homeopathic fraternity is going to wards, go to the hospital, see patients. 10 times you'll see patient, 9 times you'll fail. At least first case when you treat, you'll get that satisfaction. So training is very important. Here we don't want to come out of our classrooms and we just want to without making efforts we want to learn. So this is not possible. Seminars and webinars and lectures are just a part of learning, but majority of the time the real learning is from our patient, and we have to visit hospital and wards where we can actually see what is pallor, where we can actually see what is hemodynamic instability, where we actually see how to keep a input output charting, and how do we actually live design the therapeutic strategy. You understood? Yes. Of various illnesses. Now, in this case, it's an acute abdomen. How do we actually use a bogus concept of treatment? How do we understand materia medica, and how do we use those materia medica drugs in the pathological cases which comes to us? And differentiation of remedies and referencing. Most important is referencing. I have seen in hospital a student or an intern will come, take the history, and will expect that the consultant will give a remedy. But by doing this you are actually ending the process of learning. Till the time you don't put your mind to that particular case, you don't construct a totality, don't differentiate the remedy. Because as we have seen in this case, on the totality, remedies like bryonia and arsenic and china and all these things are coming. So why do we give Mercsol? But only after detailed analysis we realized that Moxol will have a better coverage to the case compared to Bryonia and any other drugs. Yeah, so these are the few things which I feel I learn day in and day out from the cases, and I want all my students and all my, because ultimately we have to go to the community and practice, and I want each one of us to at least feel proud of ourselves, okay, whatever I did, I am able to treat a patient. That feeling of physicianship should be there in each one of us. We should not feel helpless or handicapped. That is my motive of taking a session on this day. And I thought this will help all of you. So referencing is very important. Thank you so much.